Good morning, everyone, and welcome to another COVID-19 webinar in our COVID-19 webinar series brought to you by the National Institute for Occupational Health, the NIOH. The NIOH is a specialized division of the National Health Laboratory Services and a sister division of the National Institute for Communicable Diseases. Today, our topic is long COVID and the workplace, an update. It is the second, I think, in a long COVID webinar topics. And I am pleased to welcome quite a significant set of speakers today. Dr. Dryden of the NICD, Dr. Rubeshan Perumal, Professor Shahieda Adams, and Professor Romy Parker, the latter both from UCT, and Dr. Perumal from the Long COVID Clinic at Groote Schuur Hospital. And quite clearly, long COVID is a very important topic for us to deal with and to stay up to date with, given its significance in the overall efforts to deal with the both public health as well as occupational challenges that SARS-CoV-2 and the COVID-19 pandemic and epidemic has posed for us, and our own efforts within our different workplaces and in our different roles within the occupational health and safety spheres within the workplace, and the support that is provided to the workplace by the professionals and different practitioners. So without much further ado, I want to just put in an apology for Dr. Tanusha Singh, who's the head of our COVID-19 Occupational Health Outbreak Response Team, the OO team here. Unfortunately, she is occupied in another important engagement here at the NIH and is unable to join us today. Dr. Tanusha Singh is also the head of our Immunology and Microbiology section here at the NIH. So I'm going to ask Dr. Dryden just to prepare for his presentation. He is presenting on behalf of the partnership, that's himself, Dr. Dryden, and Dr. Waasila Jassat of the NICD. And by means of introduction, Dr. Dryden is a medical doctor who's been with the National Institute for Communicable Diseases since February 2020, where he was part of the Outbreak Response Unit and assisted with the clinician support throughout the COVID-19 pandemic. Dr. Dryden joined the DATCOV Hospital Surveillance Team in October of 2020 and has led the NICD post-COVID-19 condition project since. And with that very short introduction, I'm going to hand over to Dr. Dryden, and he's going to deal with the topic long COVID follow-up update on NICD research study findings. I will deal after his presentation with a bit of with a bit of the online housekeeping and reminders for everybody. Just one reminder, please, the raise hand function is not applicable for this webinar. We expect a very large number of people to join the webinar. And with that, I hand over to Dr. Dryden, the medical officer at the National Institute for Communicable Diseases, NICD. Welcome and thank you, Dr. Dryden, for taking the time to join with us. I see there are more colleagues in your presentation list, and you may want to perhaps introduce the overall team to our attendees. Thank you, Dr. Dryden. Please proceed.
Thank you so much, Ashraf. Good morning, everyone. Yes, as Dr. Ashraf has said, it's myself, Dr. Jassat, Caroline Mudara, Caroline Vick, and Prof Bloomberg. And with that being said, good morning, everyone. Again, I'd like to welcome you and introduce myself. My name is Dr. Dryden, and I'm presenting on post-COVID-19 condition and our early findings from our longitudinal cohort of hospitalized COVID-19 patients. Just a brief introduction to our study and its methodology. The study design is a quantitative longitudinal cohort, which will form a part of the ISARIC international cohort with 10 other countries. We hope to characterize the physical and psychosocial consequences in post-COVID-19 infection and estimate the prevalence and risk factors for post-COVID-19 condition. We have ethics approval from the University of Witwatersrand, and we are proudly funded by the Bill and Melinda Gates Foundation and we are currently sampling patients over the age of 18 who were hospitalized and subsequently discharged alive. We utilize the national hospital surveillance data to identify potential participants who are interviewed telephonically at 1, 3, 6, and 12-month periods using a CRF consisting of approximately 120 questions, including presenting symptoms, ongoing or persistent symptoms, quality of life tools, and changes in employment status, as well as the ability to perform activities of daily living. Our study population was 117,000 patients who had been admitted to hospital between December 1st and 27th of April, 2021. And after applying our inclusion criteria for those patients who had died, who were under the age of 18 and did not have a valid contact number, 61,000 patients were eligible for inclusion. Of that, 5,322 patients were randomly selected, where nearly 3,500 patients were unreachable, again due to incorrect cell phone numbers or voicemail. 371 refused, and since our enrollment, we have enrolled 1,448 between January and April of 2021. The median time from discharge to follow-up was 28 days. The median age for our participants is 51 years, where most participants are aged between 40 to 64 years. There were more females in the younger age groups than males in the cohort so far. Most patients were Black African, which is a similar proportion to that seen in our hospitalization data. 64% of patients in the sample reported at least one comorbidity, 28% required ICU admission, 55% required supplemental oxygen, and 6% required invasive mechanical ventilation. Regarding distribution of comorbid disease, nearly 33% of patients reported a history of high blood pressure, 20% with clinical obesity, followed by 18% with type 2 diabetes and 7% with HIV. Other conditions included were thyroid disease, anxiety, depression, other mental health conditions. From our cohort, we found that 18% of patients reported that they had no persistent symptoms 1 month after hospital discharge, and 82% of patients reported that they were still experiencing persistent symptoms related to COVID. From this, 33% reported 4 or more persistent symptoms. In comparison between public and private sector, we found that private patients were slightly more likely to report persistent symptoms, with 82% versus 80% in the public sector. And we found that patients admitted in the public sector were more likely to report only 1 persistent symptoms. And the biggest difference was in the 4 or more persistent group were reported, with 37% of private patients reported 4 or more symptoms compared to 24% in the public sector. With regards to the symptoms reported by patients at 1 month follow-up, the most common persistent symptoms were fatigue at 70% and shortness of breath at 32%, followed closely by headache, muscle weakness or general fatigue, and confusion or lack of concentration. These symptoms are in keeping with the currently available literature. This is just a side-by-side comparison between acute symptoms prior to hospital admission that shows the most common acute symptoms were fatigue and malaise, followed by shortness of breath, cough, fever, muscle aches, headache, chest pain, and joint pains. All but 2 symptoms, namely fatigue and skin rash, saw a decline in reporting at 1 month follow-up. And significantly, we can see that there was a sizable increase in fatigue prior to hospitalization compared to 1 month after hospital discharge. We expect that all of these persistent symptoms should decrease as time progresses, and we hope to begin our 3-month follow-up analysis relatively soon. This slide is an extension of the previous one, where we did not report overlap between acute and persistent symptoms. However, this does not suggest that there was no overlap. Again, notably, 18% of patients reported persistent weakness in the arms and legs, as well as confusion or lack of concentration. Please note that we haven't completed our full data review, and we expect that we are likely to see a decrease in the number of any other new symptoms as we correctly sort them into the relevant categories here. So it's namely this section there. Of all the patients enrolled in the study so far, 70 patients reported severe complications since discharge from hospital. 10 patients reported heart attack, 6 patients reported deep vein thrombosis, 8 patients reported stroke or a TIA, 16 patients reported pulmonary embolism, and 30 patients reported kidney problems. Patients were asked to compare their level of breathlessness from before they became ill to 1 month after hospital discharge, and there was a noticeable difference. Patients who reported that they were not troubled by breathlessness except on strenuous exercise decreased from 93% to 63%. Those who were reported breathlessness whilst hurrying or walking up a slight hill increased from 2% to 18%. Those who had to walk slower had to stop to catch their breath decreased due to breathlessness increased from less than 1% to 9%. Those who needed to rest after walking 100 meters or a few minutes on level ground increased from less than 1% to 6%. And finally, patients who were too breathless to leave the house or perform activities of daily living increased from less than 1% to 2%. In terms of fatigue intensity, patients are asked to rate their level of fatigue on a scale from 0 to 10, where 0 was no fatigue experience compared to 10 being the worst fatigue they've ever experienced. A large proportion of patients reported a level of 0, experienced no fatigue, whilst 35% of patients reported a level of fatigue greater than or equal to a level of 5. With regards to how patients felt in terms of their breathlessness and fatigue after COVID-19 infection, 32% felt that they were worse off than they had been previously. We then looked at difficulties with activities of daily living by sex, and we found that in terms of mobility, there was a majority of patients who did not have any difficulty in this category. However, 27% of females and 26% of males experienced some difficulty in mobility. In terms of the ability to perform self-care, 11% of females and 10% of males reported difficulties here. Regarding performance of usual activities such as washing, cooking, and feeding themselves, 28% of females and 27% of males reported disruptions here. About pain and discomfort, there was a higher percentage of females who reported pain and discomfort than males at 24% versus 19%. And finally, we looked at anxiety, depression, where again, females reported higher rates than males at 34% versus 22%. If we look at some of how the activities of daily living changed following the acute illness, we can easily see for the vast majority of patients, there was no change in the ability to see, hear, walk, remember, look after themselves, and communicate. However, some patients did report worsening of the activities of daily living. 21% of patients reported that they felt that they were less able to walk now than before they became ill. 17% of patients' symptoms with regards to remembering had decreased in both short and long-term memory. 9% of patients were having difficulty seeing after their illness. 5% struggled to look after themselves by washing, changing, or feeding themselves. 3% were now experiencing difficulty with hearing, and 1% had experienced difficulty with communication. Patients were then again asked to rate their perceived health on a scale from 0 to 10, where 0 was the worst health they could imagine compared to 10 being the best health they could ever report. Most people reported a health score greater than 8. However, 16% of females and 15% of males reported a health score less than a value of 6, which is lying towards the bottom end of the scale. Finally, we looked at lifestyle changes, and many of the patients enrolled in the study so far have reported that they're working a full-time job before COVID-19. Nearly 9% experienced a change in their occupation following the acute illness, and from this 9%, 70% of patients reported the main reason for the change in occupation was related to COVID-19 symptoms. In addition, we asked patients about their social habits such as smoking, drinking alcohol, eating healthy food, and performing physical activity, and found that 4% of patients who were smokers were smoking less. Nearly 20% were reported that they were consuming less alcohol, though we may need to consider the effects of lockdown on this figure. Interestingly, 53% of patients reported they were eating healthier food, but unfortunately only 23% were exercising more, whilst 34% were actually exercising less. When we compared our findings of reported persistent symptoms by sex, we found that the proportion with persistent or new symptoms was higher in individuals with comorbidities compared to those with no comorbidities, and persistent symptom prevalence was highest in the age group 40 to 64 years, and there was no obvious difference between male and female sex. On multivariate analysis adjusting for age, sex, race, presence of comorbidities, sector of admission to ICU, oxygenation and ventilation during admission, factors associated with new or persistent symptoms following acute COVID-19 illness were ICU admission. We found that patients who were symptomatic prior to admission showed an association with persistent symptoms, and this association increased with more symptoms, particularly in those with 4 or more symptoms. Positive associations with breathlessness after admission were ICU admission, pre-existing asthma and obesity, and symptomatic acute illness. And again, Black Africans were less likely to report breathlessness after discharge relative to white race. For our next outcome, self-reported non-recovery, positive associations with 4 more acute symptoms and obesity. And again, Black Africans were less likely to report non-recovery after discharge, which is a good thing. Those who admitted to ICU had 1 or more symptoms during the acute illness and a pre-existing type 2 diabetes mellitus showed an association with disability after COVID-19. Those who were male were less likely to report new or worse disability after the acute COVID. And for all outcomes previously presented, patients in the age group 40 to 64 years showed a positive association with these outcomes. However, these were non-significant, and with an increased sample population, we may find that this does become significant. Finally, with depression as an outcome, positive associations at 1 month after hospital discharge include mixed race, admission to ICU, 4 more symptoms at acute illness, and pre-existing obesity, while factors that were not associated with depression were male sex. Just a short discussion before I wrap up. Some notable limitations that we have recognized in our study so far include a selection bias, and this is towards the private sector, which we believe may be the result of better data capturing of contact details by the laboratories when testing. In addition, we also have the suspicion that there may be a response and non-response bias where sicker patients are far more likely to participate relative to healthy patients. And we do have some evidence of that where healthier patients are declining to participate in our study. We have also not only sampled patients who are hospitalized and did not include patients with mild disease who are not hospitalized. In addition, we do not have any SARS-CoV-2 negative controls to compare to our positive sample population. Regarding further project expansion, we'd like to expand our study to include non-hospitalized patients, as well as include a pediatric cohort with healthy family controls to be able to better identify appropriate associations more accurately. We are currently engaging with the National Department of Health to improve patient messaging, as well as improve the development of clinical management guidelines and healthcare worker training, and finally, healthcare service planning and provision. We're also working with the NIH to provide material with regards to occupational health service and the implications thereof with regards to long COVID or post-COVID-19 condition. Finally, I'd like to thank our team of research assistants responsible for our data collection, as well as the entire NICD and DATCOV team for all the support they provided us for the project. In addition, thanks to our partners at ISARIC in the United Kingdom responsible for our project support, and to our sponsors at the Bill and Melinda Gates Foundation. Thank you very much for your attention, and that's it from me. Happy to take any questions. I think you muted, Ashraf.
Thank you. So thank you very much. That's Dr. Murray Dryden, the medical officer from the NICD, and he has left us with quite a bit of extra time there. So before we proceed to our next speaker, yes, Dr. Dryden, just to watch the question and answer box. I think there's a few questions for you there already. If you could just attend to those questions, thanks. A reminder to everybody, Joan Christoffels, and I'm not sure who else that was, your raised hand function is not working in this particular webinar. We've got too many people to allow you to open your microphones. Please type your questions in the question and answer box. That's the Q&A box with the two bubbles at the bottom of your Zoom screen. And any other general comments, certificates and other things related, please type that in the chat box. That's the single bubble at the bottom of your Zoom screen. The other aspects of certification and so on, I will chat to later. It was also in our slides that played before we started the webinar. So thank you very much to Dr. Murray Dryden, who has dealt with the introduction and specifically looking at the research that has been conducted by the NICD team. I'm now going to ask Dr. Rubeshan Perumal just to check if he can share his slides and check his microphone and audio. And by way of introduction, Dr. Rubeshan Perumal is a pulmonologist at Groote Schuur Hospital and the University of Cape Town. He has research affiliations at the Center for Lung Infection and Immunity, that is at UCT, and the Center for AIDS Program and of Research in South Africa and UK at UKZN, where he leads research portfolios. Dr. Perumal holds a master's degree in public health, medicine and M.Med, apologies, and pulmonology and MPhil in pulmonology, and is currently completing a PhD focused on the pharmacokinetic, pharmacodynamic optimization of tuberculosis treatment. Dr. Perumal is a past recipient of the Fogarty International Clinical Research Scholarship and was named a Global Young Physician Leader by the Inter-Academy Partnership. He presently leads the post-COVID-19 lung disease service and research program at Groote Schuur Hospital and University of Cape Town, the partnership there, and is a member of the World Health Organization working group on care pathways for long COVID. And with that introduction, I see, thank you very much, Dr. Perumal. You've got your slides shared and in maximum size. If you could just check your audio, and I'll hand over to you, sir.
Hi, good morning, Ashraf. I'm just checking that you can hear me loud and clear.
Perfectly, thank you.
Wonderful. Well, thank you for that very kind introduction. It's a huge pleasure to be delivering this talk, particularly to this audience on a subject of rapidly growing public and scientific interest. You know, long COVID is an uncomfortable subject, even for myself as a leader of a long COVID service, because there really are more questions than there are answers. And our patients are pleading desperately for help. And this is a feeling which has left many healthcare workers who have to accommodate the needs of these patients feeling ill-equipped to manage them. I hope that my talk today will touch on a few of the scientific hypotheses underlying potential biological mechanisms for long COVID. I might provide some insight into how we are approaching some of the post-COVID sequelae, particularly lung disease, and I might be able to share with you some ideas about how we can organize our healthcare services in anticipation of what is coming. So I remember quite vividly the sense of victory I had last year in the very, very beginning of the first wave when we discharged our first ventilated patient with COVID-19. He had suffered severe pneumonia, pulmonary emboli, and septic shock. And it was really an incredible moment of victory for us to see a survivor from this terrible illness. But I saw the patient again 2 months later, and I was absolutely dejected. He was alive, but still requiring home oxygen. He was exhausted beyond all belief. He hardly managed to get to the bathroom, and he had been plagued by muscle aches and chest pain ever since leaving the hospital. And many of us have spent the past year and a half or so at the bedside of some of these very sick patients, like the patient depicted in the top right corner of the slide. A patient turned face down in submission to a deadly pneumonia, their lives depending on a tower of infusions and the bellows of a mighty ventilator. And I think we thought our battles would be over there. But I'm beginning to realize increasingly that our patients' needs seldom end at the discharge. Now, while most of our attention has focused on the containment efforts in addressing the surge of cases with severe pneumonia across the world, our clinical response has to shift to a new emphasis on post-acute COVID care. We are now accruing a very large cohort of survivors in this country and globally, and their care needs are becoming ever apparent. Cases of incomplete recovery and the incapacitating persistence of illness have dominated the news headlines around the world. South Africa is little different. And these patients are calling out for help. And we are now just beginning to gain sight of the tsunami that is following swiftly behind the waves. Look, globally and locally, recovery rates are impressive. We are seeing that more than 90% of patients from the global cohort recover from acute COVID-19, and about 95% of South African patients recover from acute COVID-19. But the possibility that approximately 30% of survivors may face a life of incomplete recovery should be met with deep concern. I mean, we see that if we extrapolate that 30%, then, as we stand, there are somewhere between 14 and 42 million people in the world who are struggling with persistent symptoms. In this country alone, 500,000 people are estimated to be in need of long COVID care. So this is, a problem which is likely present currently, but for which we don't yet have services to absorb and attend to the need. And so we may be under-perceiving it as healthcare workers because we just don't have the contact interface for these patients to make contact with us. Well, in this study, which was looking at reporting the clinical status of hospitalized patients at 4 months from discharge, they identified more than 50 clinical sequelae in these patients. And certainly you see that dyspnea, fatigue, paresthesia, and memory difficulties predominated. It is quite stark that 4 months after discharge, over a third of ventilated patients are reporting ongoing fatigue and shortness of breath. And so recovering these patients from death's door in the acute period is only the beginning of a long journey of ongoing care needs. This Venn diagram is demonstrating the nature of the deficits which patients remain with after discharge from acute care. And each bubble represents a small group of patients, and they each fall within a broad group of persistent deficits. And so if you look at this group of 5 patients here, you see that they are caught within the green boundary, within the red boundary, and within the blue boundary. And so they are experiencing symptoms in fibrotic lesions, from cognitive impairment, and from psychiatric symptoms. And this is perhaps the most worrying characteristic of long COVID, that it is causing restriction in many domains at the same time. And it's not going to be possible to deal with each of these problems in silos. Synthesizing the rapidly accumulating reports of persistent symptoms, this systematic review published in the International Journal of Clinical Practice shows that the frequency of symptoms reported at 3 months varies quite significantly between studies. And it seems like the variability arises from the way in which symptoms are elicited from patients, whether they're self-reporting or whether they're derived from clinical records. Depends on the severity of initial illness in the surveyed population, and sometimes even regional differences in help-seeking behavior. Certainly within some cultures, like my colleagues in Italy tell me, it is frowned upon to report on lingering symptoms from an acute illness. And then in other parts of the world, like the UK, where the culture accommodates ongoing symptom reporting, they are reporting much higher prevalences of lingering symptoms. Now, whether these geographic differences are biological or related to behavioral and socio-demographic factors, we're not yet clear. But there clearly is this highly variable nature to long COVID's prevalence. The study at the bottom now arises from the ISARIC WHO clinical characterization protocol studies. And what you see here is simply a rising prevalence of long COVID, essentially the feeling of non-recovery with the severity of initial illness. Now, there are 2 important points to make here. One, that when patients have severe illness acutely, they are at greater risk for developing long COVID. But epidemiologically, the vast majority of patients have mild COVID. And so numerically, we are going to see a far greater proportion of our long COVID patients arising from the mild acute COVID population. So it's important to remember those 2 things. Patients with severe illness are at greater risk, but by and large, the majority of patients with long COVID come from patients who are mildly and sometimes even asymptomatically infected and diseased by COVID-19. Equally worrying to me is this finding recently published in the BMJ, showing that not only were persistent symptoms a problem, but the discovery of new major medical diagnoses in the first 6 months after acute COVID-19. And you can see that these patients in the first 6 months after their acute illness have a 6 times greater risk for a new lung disease, a 3 times greater risk for a major adverse cardiovascular event, and 3 times greater risk for liver disease, and almost 2 times greater risk for chronic kidney disease. So it is clear that the physiological embarrassment from acute COVID-19 is unrelenting. Well, we do now need to organize ourselves in a way that allows us to approach the illness with some level of agreement amongst the scientific and clinical community. And to do that, the first step is to agree on definitions and nomenclature. At least 4 major agencies in the world, the NIH, the CDC, NICE, and NICD in South Africa, have all issued guidelines or position statements on long COVID. The NIH describes the post-COVID syndrome when symptoms persist for more than 12 weeks, and they describe ongoing symptomatic COVID-19 between 4 and 12 weeks. The CDC reflects a diagnosis of long COVID when symptoms are present for more than 4 weeks. NICE similarly agrees with a combination of CDC and NIH, and they describe long COVID for more than 4 weeks, but the post-COVID syndrome for more than 12 weeks. And in South Africa, we've chosen to agree with both of the CDC and the NICE, and we define long COVID as the persistence of symptoms for more than 4 weeks. We don't make a distinction between the 4-week mark and the 12-week mark in our current position statement. Well, who's at risk for developing long COVID? Well, firstly, it turns out that it's people with advancing age, female sex, comorbidities, and increased BMI. But very interestingly, certain symptom clusters in the initial illness portend a greater risk for the development of long COVID. And this cluster, codified as the severe cluster, is comprised of patients who, during their acute illness, who have severe fatigue, continuous chest pain, confusion, meal skipping, and early onset of shortness of breath. And meal skipping turns out to be a very prominent predictor of the risk of long COVID. And we don't yet know the biological mechanism for that, but certainly having reviewed all of the literature, existing literature on this subject, meal skipping, keeps finding its way into one of the very high level predictors for the development of long COVID. And as I showed you, severity of illness is an important indicator. Well, this study led by Tim Spector and colleagues in the UK, looking at a mobile application-based symptom reporting program in which they invite patients to download the app from the time of their diagnosis and continue to report their symptoms longitudinally. They found that having included a large number of variables, initially 24 variables in their model, they were able to refine their model to a 3-factor model, including only age, sex, and the initial number of symptoms. And using that final model with just 3 variables, they were able to predict with greater than 70% accuracy the development of persistent symptoms at 56 days from acute illness. And you can see that the presence of 5 or more symptoms is really a strong predictor for the development of long COVID. For me, what was also interesting was that hoarse voice and headaches were quite prominent predictors of the development of long COVID. I did notice in my clinical practice that a hoarse voice tended to be present in patients who had some other predictors of long COVID, severe illness, dense fatigue, and many symptoms present at the initial illness. So it might be a collinearity with those factors, but it's still to be determined what the biological mechanism is. So here's the crux of the whole thing. This is my summary of the potential mechanisms underpinning the development of long COVID. Now, there are a few important features of this depiction. The first is that right here in the center is long COVID. And to get to long COVID at the center, you have to be able to separate out these things at the periphery. You have to be able to rule out acute COVID-19 related complications like lung fibrosis. You've got to take that and chuck it out of the bag. Then you've got to take post-ICU syndrome problems, which is a well-characterized post-ICU phenomenon for any disease which lands a patient in an ICU for a protracted period of time. And that's critical illness, neuromyopathy, and autonomic instability, and so on. And you got to take those sort of problems and put them in this particular basket. Then there are hospital-related problems, thrombophlebitis, DVT, pulmonary embolism, pressure injuries, muscle atrophy, and so on. We've got to remove that from the bundle. And then there are damage from secondary infections, damage to the lungs, heart, kidneys, and so on from secondary infections. And then what you're left with really is what I think is long COVID. Unexplained persistence of symptoms can't be accounted for by any of the other biological mechanisms underpinning acute COVID-related complications, post-ICU syndrome, hospital-related complications, and superimposed sepsis. And the constellation of these symptoms have to be explained biologically, and we have to then look to where the potential explanations might be. And so far, there are at least these 8 explanations for them: autoimmunity, persistent viral infection, mast cell activation, microvascular thrombosis, postural orthostatic tachycardic syndrome, metabolic derangement, dysbiosis, and persistent brain dysfunction. I'm going to go through some of them very quickly. So, we now know from the studies of autoimmunity in patients who had severe illness that there are antibodies to phospholipids and to type 1 interferons at a much higher prevalence than one would expect for the general population. And it seems that SARS-CoV-2 is able to breach the breach the epithelial surfaces so that self-antigens are exposed and autoimmunity can develop, and this can happen in the airways quite prolifically. And we get a break to self-tolerance because of the autoantigens which are now exposed, and you get a lupus type autoreactivity. And in fact, in a study which is now currently preprint, you see that the presence of a high titer positive ANA is about 44% in these individuals with acute severe COVID-19. And that's very high in relation to the 5% or less prevalence we expect for the general population. And we see high level antibodies in rheumatoid factor, RNP, centromere antibodies, and phospholipids, and so on. These tend to correlate with the peak CRP during acute illness. And it seems like autoimmunity might be one of the best explanations for persistent symptoms. And if it is true, then it explains why we now have trials of steroid, immunomodulation, and immunosuppression for long COVID. Look, viral persistence is, in my mind, the second most attractive and biologically plausible explanation for long COVID. Certainly, the mechanisms of action for viral persistence will include low-grade infection with direct injury, for example, to enterocytes in the gut, to olfactory neuroepithelium, where you might get diarrhea in the gut or persistent as anosmia in the neuroepithelial involvement. Another way that persistent infection could give rise to symptoms is through indirect injury. So, these persistent presence of viral nucleic acids may lead to a persistent state of stimulated immunity. And we do have evidence now that the gut may serve as a site for reservoir chronic infection. And depicted here are gastrointestinal tract biopsies from patients who are 4 to 6 months after their acute illness. And you see fluorescing quite brightly here in green is the presence of viral nucleic acids. And this is 4 to 6 months after acute infection. And we suspect now that the gut might be the reservoir for low-grade persistent infection. And in fact, antigen persistence can also potentiate autoimmunity. And so it links up with the autoimmunity that I just talked about in a previous slide. And then lastly, SARS-CoV-2 antigens are not just simple antigens, they're super antigens. And super antigens are those antigens which elicit a very dysregulated immune response. They create a type of ineffective immunity, but a florid amount of immunity. So a robust immune response, but an immune response which is not targeted and precise enough to neutralize the target. And so that leaves us in a state of chronic inflammation. And it gives an explanation for why there are some biomarkers which remain higher than expected, like ferritin, which remains elevated for weeks after the acute infection, suggesting some degree of chronic inflammation. And so it explains now why we have trials of type 1 interferon and other interleukin potentiating drugs. And so we have to use antivirals for that. And antiviral drugs themselves are now becoming increasingly sought after. Nitrous oxide seems to be leading the pack in that regard. The mast cell activation syndrome is a multi-system disease or illness. It's characterized by a relapsing remitting course. And it is well documented now that mast cells are hyperstimulated after infection with SARS-CoV-2. And you can see that through the mediators of histamine and interleukin-6, you get a host of multi-system affectations: tachycardia, urticaria, diarrhea, muscle aches, anxiety and depression, nasal congestion, wheezing and fatigue. And it gives credence to the possibility of mast cell activation leading the presentation of long COVID. And in studies which have now emerged where they are studying urine histamine levels, we see very elevated urine histamine levels in patients who are presenting with long COVID. Interestingly, patients who are on mast cell stabilizers or antihistamines at the time in the last year, they seem to have a lower incidence of infection and a lower prevalence of long COVID. And that is arising from established cohorts of mast cell activation syndrome patients who were on mast cell stabilizers and antihistamines before COVID-19 came to the fore. And therefore, it explains why we're now pursuing antihistamines, mast cell stabilizers, and a low histamine diet for the treatment of long COVID. Now, postural orthostatic tachycardic syndrome is a condition in which has numerous overlapping symptoms with long COVID. You can see it includes fatigue, headaches, brain fog, muscle fatigue, gastric dysmotility, diarrhea, shortness of breath, nocturia, and a host of dermatological manifestations. And really what it is it's an autonomic dysfunction. In patients who recover from COVID-19, there is a greater than expected incidence and prevalence of autoantibodies to alpha and beta adrenergic receptors, leading to increased sympathetic responsiveness. And so you get an exaggerated sympathetic response when the sympathetic nervous system is stimulated. And the diagnosis is made with a simple a test where a patient going from supine has their heart rate measured here. You can see this patient's heart rate is at 105 or so at the start of the test. They stand for about 10 minutes, and then very rapidly their heart rate starts to rise. And when their heart rate rises by a certain threshold, 30 beats per minute, without a drop in the blood pressure, we make the diagnosis of postural orthostatic tachycardic syndrome. If the blood pressure falls, then that's orthostatic hypotension, and it's got a different mechanism to this condition. And therefore, there are now trials looking at volume expansion, compression stockings, fludrocortisone, ivabradine, and beta blockade for the treatment of POTS. And then lastly, there's this potential for brainstem dysfunction because SARS-CoV-2 exhibits tropism for the brainstem. You know, the brainstem is highly ACE2 expressing. It has numerous co-receptors other than ACE2 for SARS-CoV-2. And we know that SARS-CoV-2, like all the other coronaviruses, are neurotropic viruses. And we know that there's dense neurological involvement in a subset of patients with acute illness. And it's probably a multi-hit pathology, you know, direct viral invasion, neuroinflammation, microthrombosis in the brain. And these are all evidenced in post-mortem studies of COVID-19. And it makes sense then that given all the nuclei present in the brain stem and in the midbrain, that you can give rise to a whole host of multisystemic symptoms. And for that reason, steroids and neurochemical manipulation, including serotonin, SSRIs, and so on, are increasingly being used in patients with long COVID. Now, post-COVID lung disease is of the greatest interest to me, given that the lung is the most severely affected organ from acute COVID-19, and the lung is the portal to systemic infection. You know, the lung can be involved acutely and develop complications from the acute infection, or there can be long COVID presentations which are difficult to link up with the acute illness. You know, the development of an organizing pneumonia, even in patients who didn't have severe ARDS in the initial presentation, unexplained dyspnea in patients with very little objective findings in the chest, coughing in patients who have little parenchymal involvement, costochondritis, I've seen prolifically, very, very debilitating symptom, really occurring post-acute infection, hardly ever present during the acute disease. And then dysfunctional breathing, which I'm sure Romy will talk about a little later. So when patients have acute infection, they have this multifocal airspace disease, as you can see in this slide, and they can terminate on one of three possibilities. One, complete resolution. Two, multifocal ongoing ground glass with atoll sign, this haloing pattern characteristic of an organizing pneumonia, or dense fibrosis, totally destroyed structurally abnormal lung. And I want to add another group, this post-TB COVID lung disease cohort in South Africa. You know, about 10% of my cohort at Groote Schuur is comprised of this very debilitated group of patients who had post-TB disease. You can see upper lobe predominant fibrotic disease, but now superimposed by mid and lower zone predominant changes from COVID-19. And these patients have been taken just over the edge by COVID-19. They were frail from their post-TB lung disease, but still functional. And COVID, sadly, has taken them, you know, down a steep trajectory of lung function loss, new fibrosis, and into the realm of disability. Well, fibrosis from COVID is really no different to post-infectious lung fibrosis seen in other lung conditions like ARDS and viral pneumonias. It's driven through a whole host of dysregulated healing. The natural history is not known. It might very well be a progressive inflammatory ILD, but for most of the previously known post-infectious conditions, there's a static lung disease. There's likely to be substantial morbidity because lung function is lost irreversibly. And as people age, they're going to naturally lose lung function in accordance with lung function loss with aging. And at some point, their lung function will deteriorate beyond a point of functional requirements for daily life. And we're going to see patients becoming disabled from that going forward. And as I showed you previously, advancing age, heart rate above 100 beats per minute, long hospital stays, ARDS, and ventilation with extensive radiological findings all predict lung fibrosis going forward. And we now have trials for antifibrotic agents, antivirals, immunosuppressive therapy, hyperbaric oxygen acutely, stem cells for patients with progressive fibrosis, and even lung transplantation, like a case in Johannesburg earlier on in the epidemic. Well, post-COVID organizing pneumonia, look, this is a novel concept. It's rapidly emerging as an area of interest. It's what we're finding is that when we do biopsy studies of these patients, they don't have hyaline membrane ARDS like we expect. They in fact have a different process called acute fibrinous organizing pneumonia. And this is characterized by fibrin balls rather than hyaline membranes. And these are characteristic of organizing disease, which is an exquisitely steroid sensitive process, but can cause profound hypoxemia when left untreated. And the natural history is that, it's a resolving cause over time and highly steroid sensitive. And so we really have to be able to identify these patients within our cohorts to know who might benefit from steroids, from immunomodulation, from immunosuppression, and even from monoclonal therapy. Okay, what do we know about the trajectory of this illness? Well, in this study published in the Lancet, they took patients with persistent respiratory symptoms. They follow them up at 3 months, 6 months, 9 months, and 1 year. And they really included only patients with severe disease, high flow or non-invasive ventilation, and they chose to follow patients without comorbidities because they tried to limit confounding from other illnesses. And what they found is that at 12 months, 33% of patients still had diffusing limitation in the lung. About 11% of patients had lung volume loss persisting, and about 5% of patients were still reporting significant breathlessness. And about a quarter of patients had structurally abnormal lungs on CT. Now, while the overall picture here is of progressive improvement over time, I hazard to say that it's unacceptable that a viral illness should leave a third of people with poor diffusing capacity in the lung a year later. I think that it's not simply a case of people will recover with time. I think we still have too many people unrecovered so far down the line from an acute viral illness. I think, if COVID wasn't the dramatic pandemic that it turned out to be, we'd find it hard to explain why a virus could cause such persisting symptoms so far down the line. Well, how then should we approach this? Well, here's a really well-designed study by Catherine Mayall in the UK. They took 837 hospital survivors. They found 325 of them who had persisting symptoms 4 weeks after their discharge. 42% of those patients, all of the patients got lung function and an X-ray, and 42% of them had normal lung function and normal X-ray, and they got sent to rehabilitation. About 34% of them had an abnormal lung function, but a normal X-ray. And there we know that abnormal lung function can arise from other systems like the heart, the neuromuscular system, the chest wall, and so on. And so those patients got referred to multidisciplinary clinical care because the lung was unlikely to be the source of the abnormal pulmonary function test. And then they found about a quarter of patients abnormal lung function and abnormal X-ray. Those patients should come to me as a pulmonologist, and we interrogate those patients further. And according to this study, we find about half of that cohort have an organizing pneumonia. And when you give them steroid at about 0.5 milligram per kilogram, almost all of them show improvement in their symptoms. They all gain lung function significantly, and they all improve their diffusing capacity of the lung. Well, this schema published in the British Medical Journal says, well, suggests how we should tackle patients with long COVID. Well, they say a primary care contact is sufficient with an assessment of comorbidities and optimization of comorbidities, a nice thorough clinical evaluation, at least lung function, chest radiograph and ECG, symptomatic relief with basic therapies, referral to rehabilitation, to OT, to self-care and support groups, and then having in place well-defined referral criteria and well-established pathways for upward referral within the healthcare system. And that's part of what we need to do now going forward. We need discharge planning, we need systematic follow-up, we need the establishment of self-care, guided self-care and support groups at the primary care level. We need to listen, we need to validate the sufferings of our patients, and we need to reassure them as much as we can, not that things will get better or that we know all the answers, but that they are within a system which is going to strive to find solutions for them. We need to call on the primary care system to be our buffer and our screening sites for the huge tsunami of post-COVID patients who are going to look for care. And then we need to organize ourselves within the higher levels of care to define and to determine who should lead post-COVID services. How can we make them as multidisciplinary as possible? Should they be located in central services or regional services? Or should specialists come out to primary care facilities to join clinics there? And can we continue to rely on primary specialties like we are doing now to lead these services, or can we find a better way with multidisciplinary care? Well, what's the impact of this whole long COVID phenomenon? Well, for me, the fact that there is multi-domain affectation affecting physical, emotional, social, and occupational domains tells me that this is not going to be a simple walk in the park with a consult, with your general practitioner able to solve all your problems. We really need to be able to cater to all of these deficits. We have heard already about the fact that 45% of patients have to change their work schedule. 22% of our long COVID patients have lost their work completely, that they attribute this change to fatigue, concentration impairment, cognition changes, and an disabling fear of reinfection at their workplace. And I've been left with these major questions. These patients come to me and say, look, I'm working for an employer who doesn't yet have a system in place to deal with me. I need you to tell me what to do. Can you put me off work until my employer finds a way to deal with me? And so I'm left struggling to find ways to balance the desire to get people returned to work and gainful employment and have the economy going on, but in a way that respects the patient's symptoms and symptom burden, and in a way that also is responsive to the employer's need for clear ideas about how we can return their employees to work. And so I've used a combination of special leave, temporary disability when needed, and in some patients, when, for example, they've developed prolific fibrosis in the lung, even looking for medical boarding and permanent disability, we need to agree on how to assess impairment and functional assessments in these patients, because sometimes all of our tests are normal and the patient is still heavily impaired. And I find the 6-minute walk test to be quite useful there. It's a sub-maximal test. It does test a multi-system limitation to activity. And I'm often able to use that to declare impairment and to suggest ways forward. Determining fitness to work is complicated, because I think the better option than determining fitness to work is to find ways to accommodate employees in new ways within the work environment and to modify their tasks, if at all possible, in a way that makes them feel confident to return to work and in a way that satisfies the employer's need for productivity. We should be thinking about phased returns to work and more flexible working schedules. And we need to encourage support programs for those people returning to employment. And I think the employers would do well to establish rehabilitations even within the employment environment. We also now have to accept that we have to divert resources to a new and largely unexpected problem. We didn't know that we were going to face this growing need for long COVID, and we have to divert resources to this new problem. So what's the take-home points? Well, acute COVID-19 casts a long shadow. This is going to be a problem that we deal with far into the future. Long COVID is an inescapable public health priority, and we have to find ways to organize ourselves in response to that need. It is the scale of the peaks of our waves of acute illness, which will largely determine the burden of long COVID. We have to coordinate ourselves in a multidisciplinary fashion because the patient's deficits are rising from multiple domains. And we simply cannot allow the post-pandemic world to be characterized by large-scale persistent impairment and disability. This cannot become the polio of our time. And to do that, to avoid total disability in the post-pandemic world, we have to do better at preventing and treating acute illness. We have to understand the mechanisms for the development of long COVID. We have to identify those patients at risk and try to find ways to mitigate against progression. We have to identify effective interventions for long COVID, and we need to rapidly develop service models for the care of patients with long COVID. And with that, I thank you. On the screen now are the pictures of our long COVID clinic, showing how we have to intensively interrogate these patients' symptoms so that we can find opportunities to better their care. So thank you very much, and I look forward to questions.
Thank you very much, Dr. Rubeshan Perumal, the pulmonologist at the Groote Schuur Hospital Lung Clinic and associated with the University of Cape Town. Thank you very much for your contributions, Dr. Perumal. There are some questions for you already in the question and answer box. I'll encourage you just to go take a look there. If you could, in the meantime, just unshare your slides, it'll be appreciated. Thank you. Our next topic is dealing with long COVID and the occupational health implications after we've heard from the researchers as well as the clinical experience of Dr. Perumal and the research that he shared with us, information he shared with us. Professor Shahieda Adams is going to do the next topic for us. She is with the University of Cape Town, and by way of introduction, while she's preparing to share her slides and just check her microphone and audio. Professor Shahieda Adams is an associate professor at the Division of Occupational Medicine, School of Public Health and Family Medicine at the University of Cape Town, and the consultant occupational medicine specialist in the Occupational Medicine Clinic at Groote Schuur Hospital. She holds a joint appointment in the Western Cape Government, Department of Health, and the University of Cape Town. Prof. Adams is currently the director of the Center for Environmental and Occupational Health Research and is chair of the Division of Occupational Medicine in the College of Public Health Medicine for the CMSA. Prof. Adams holds the following qualifications: the MBCH PUCT, PharmMed at US, the DOH MMed Occupational Medicine, FCPHM in occupational medicine, and a PhD in public health. I'm going to pause there before I go on to the other areas of occupational medicine specialist to ask her just to share her slides. At the moment, Shahieda, we can see your desktop where the presentation is not yet activated. If you have some difficulties, let us know, because then we can perhaps share the presentation from our side. In the meantime, a reminder to everybody, please use the question and answer box for your questions related to the content of our presenters' slides and their presentations, our speakers. Do not type general comments in our question and answer box. Please use the chat box for that. We'll appreciate that greatly. Thank you very much. I see that your slide is shared and as well as maximized. If you could just check your audio.
I can hear very well. Can you people hear me?
Perfectly. Thank you very much. Please proceed.
So thank you, Ashra, for that introduction, and thank you for inviting me to speak, I think, on a very important topic. Dr. Perumal's penultimate slide on the implications of long COVID actually summarized my whole talk, and so I'm wondering whether I even still need to speak. But perhaps I think some of my presentation will focus on the difficulties from an occupational health perspective that we encounter when trying to deal with patients with long COVID. Sorry. Okay, so my talk outline, I thought I'd speak very briefly on COVID outcomes and the burden on the workplace. I'll spend some time speaking to occupational health and safety policy on COVID as it pertains to long COVID. And I've sort of had to cherry pick from the existing legislation on occupational health and safety and COVID, as well as legislation pertaining to the compensation for occupational injury and diseases, because that would cover in part the whole issue of impairment and return to work. I'll speak a little bit to social security and sickness benefits because I get queries on an almost daily basis, and it's, I think, very difficult area for most of us. And then speak to the challenges in treatment and return to work for long COVID cases. And this primarily relates to the absence of services and where do you refer these patients, what do you do with them, which I think Dr. Perumal has very elegantly already captured in his talk. So I've kept mine quite simple. So in terms of clinical presentations, that we know that a fairly high percentage of people will be asymptomatic after becoming infected with COVID-19. Some will go on to develop symptomatic mild disease. Some will go on to develop symptomatic moderate disease, and some will go on to develop quite severe disease. And in the last two categories, those people would usually require hospitalization and additional treatment and interventions. The outcomes span a sort of myriad of outcomes. The vast majority of patients, thankfully, go on to full recovery. There are some who go on to full recovery, but over an extended period. And I've used the 12-week definition. I note that South African definition for long COVID is actually 4 weeks. There are some who go on to have an extended recovery and continue to have symptoms beyond 12 weeks, but there's no end organ damage that one can ascertain. And then the patients who undergo extended recovery but have permanent sequelae due to end organ damage or involvement, they also a really, I think, difficult category of patients to manage, and those would often end up in specialist care. And unfortunately, there's a certain percentage of patients who succumb to the disease and who die. So in general, the patients that will end up in your occupational health practice or coming to you for advice would be in those three categories that I've put down there in bold. So those extended recoveries, they don't quite understand. They were, they had mild COVID, but they just sort of can't get back to work, and it's a month or two, and they only get their 10 days or whatever, and they should have been well, but they're not well. So they'll come for fitness to work assessments, what's going on. The extended recovery, more than 12 weeks, is where your long COVID patients will often fit in. Nothing really wrong. They've been to see a physician, but the fatigue, the neurocognitive effects is really making it quite difficult for them to work as before. And then the extended recovery with permanent sequelae, where there may be cardiac, lung complications, neurocognitive problems. They may go on to require more intensive investigation and specialist assessment. So it's estimated that about 1 in 10 patients in the UK have symptoms beyond 12 weeks. And when that study was done, that would sort of translate to about 4,000 people a day going on to develop long COVID. And that's in the setting of limited testing, because the UK had quite strict testing criteria. So they think it's most likely an underestimate. The International Lead Patient Survey, which is still in preprint, identified that about 22% of people will remain off sick 7 months after infection, and 45% of them would work to reduce capacity. So these are people who are not 100% fit, who, for whatever reason, are not able to return to 100% productivity and do the job as before. There are two measures that are thought to promote sustained return, and many of the studies on long COVID around sort of workplace issues are still being done. So there's not a lot of data out there. But the two measures that do appear to support a return to work is a phased return, which is longer than the typical 4 to 6 weeks. So these patients need longer assistance and support to get them to return to work, and regular managerial review and readjustment to reflect the relapsing remitting nature of the condition. And we know that long COVID patients have good days and bad days, and one day they seem to be functioning at 100% capacity, and then they need to take off the next 3 days because they are so fatigued they can't do anything. So it requires lots of understanding, support, monitoring in the workplace. So I thought the areas that were sort of relevant to occupational health practice as it relates to long COVID would be sickness absenteeism, how to manage it, the whole fitness to work, because I think a lot of these people infected with and will go on to develop long COVID will probably end up in occupational health practices or workplace-based clinic with an assessment, or what we would call a return to work fitness in our sort of language. There would be a whole emphasis on the return to work process and how one manages that. And often the occupational health doctor or nurse is very heavily relied upon to give advice in this regard. There's a legal obligation to report as well if it was an occupationally acquired COVID-19 case. And then there's the whole issue of managing incapacity in the workplace, which is often quite messy because you're sort of stuck between wanting to safeguard your patient's health and safety and their job security, but also needing to work within the parameters of labor law and pension funds and company policy. And often the occupational health practitioners are also tasked with facilitating access to social security, whether this is your pension fund, ill health retirement benefits, UIF, etc. So I thought we'd go to the legislation because there's been a raft of legislation in occupational health and safety and compensation matters as it relates to COVID, and the Department of Employment and Labour has been quite nimble in getting this legislation out quite quickly. So the first piece of legislation I want to draw your attention to is the Directive on Occupational Health and Safety Measures in Certain Workplaces that was brought out on the 28th of May of this year. This is actually the third directive, and it replaces the previous two directives issued in last year. And it really focuses on the occupational health and safety measures and practices that need to be implemented to prevent, control, and manage COVID in the workplace. Because certainly at the beginning of the epidemic, there were clusters of cases in workplaces, and some of these were driving up our numbers quite considerably, and the workplace was seen as potentially a site of sort of super spreading, as it were. And so there was a need also to advise employers, how do you protect your workers? What do you need to put in place so that we can keep the workplace going amidst a devastating pandemic? I've sort of handpicked bits and pieces out of the legislation because you can imagine the focus here is not on long COVID at all, but that I've handpicked certain bits and pieces that I thought might be relevant. So in terms of administrative measures, section 4, it says that a workplace or an employer must notify its employees that's subject to a certain section if they are sick or they have symptoms associated with COVID, that they must take paid sick leave in terms of section 22 of the Basic Conditions of Employment Act. So if we consider long COVID symptoms to be symptoms associated with COVID, which seems perfectly reasonable, what this directive is saying is that these people are entitled to sick leave. However, we know that under BCEA, most of us qualify for about 30 days in a 3-year cycle. So 10 to 12 sick leave days at most as a bare minimum. Some employers give a little bit more, but most employers basically stick to BCEA. So you can see this directive is quite inadequate in addressing the need for sick leave amongst patients with long COVID. Another part of the directive says that we need to inform the National Institute for Occupational Health in accordance with the Department of Health guidelines, either directly or through an employers association. So there's a set of data that they collect, and we'll go to that next. around workplace cases of occupation of COVID. It doesn't have to be occupationally acquired COVID. So workplaces have to report to Department of Health. Those cases that are considered to have been acquired in the workplace need to be reported to the Compensation Commissioner in terms of a directive on compensation for workplace acquired COVID disease. So the guideline on the submission of work-related health data from workplaces, COVID work-related health data, interestingly enough, also requires you to provide details on the post-infection outcomes of those testing positive, including the return to work. So there's a table in that document where they actually ask a host of data, a host of questions around return to work, and I'll show an excerpt from the table now. And again, if there's evidence that the worker contracted COVID arising out of and in the course of employment, that you need to lodge a claim for compensation for these workers. So this is table 4, which is from that guideline on the sorts of data that must be reported. But when it comes to the return to work fitness level, there are different categories of fitness for work. So when an employee comes back, he could be fit for his own job, no problems. He could be fit, but he might need accommodation, fit with restrictions. There's certain things he can't do. He could be temporarily unfit or unfit with review or permanently unfit. So implicit in this guideline is a recognition that there's a variety of presentations post-COVID that workers could present with when they are meant to return to work. Taking you to the Directive on Compensation for Workplace Acquired COVID. This one came out in July of last year. And it outlines what a workplace-acquired COVID-19 diagnosis relies on. So there must be an assessment that somehow there's an inherent risk for you to acquire COVID in your workplace. There's exposure to a known source of COVID, and this could be a fellow employee, or you're someone who has to travel for your job, and you go to areas of high risk, and that is how you contract COVID. The diagnosis must be reliable, so based on PCR or whichever test is acceptable to the Department of Health or WHO guidelines. And obviously, there must be a chronological sequence between exposure at the workplace and the development of symptoms. The directive goes on further to speak about the risk stratification based on occupation and and it speaks about high-risk workers, and that would typically be your frontline ICU workers, people who are doing intubation on COVID patients, and it sort of lists categories of people there through to moderate and low-risk people. However, interestingly enough, it ends off by saying that all employees, regardless of occupation, are entitled to make a claim for compensation in the event that they contract COVID-19 at the workplace. And again, in the Western Cape, and I can only speak for the Western Cape, in the earlier part of the pandemic, we certainly had clusters of cases in some of our factories, sort of specifically a pharmaceutical company comes to mind, where something like 50 to 60% of people on one shift were tested positive for COVID, many of them asymptomatic. So those people would probably have qualified for occupationally acquired COVID because it was at a time when it wasn't that well entrenched in the community. That determination obviously has become a lot more difficult now. The directive also speaks to impairment, and it says that assessment of permanent impairment shall be determined 3 months after diagnosis and when maximum medical improvement has been reached. So this is a bit problematic because in many cases, the diagnosis of COVID will only be made at 12 weeks, long COVID. And then to get to maximum medical improvement, you ideally want to put your patient through a period of rehabilitation. So this is a problem. However, it does say the degree of impairment will be evaluated based on the medical complications from the affected body or systems, which also is not that easy in long COVID because you often can't find objective evidence of target organ damage. And where there are medical complications or additional tests required, these must also be provided. So if you've done an echo or you've done a CT scan or whatever, you need to provide evidence of that and why you did it. Some of the benefits, so it speaks to temporary total disablement, However, it says that payment for temporary total disablement due to infection shall be made for as long as such disablement continues, but not for a period exceeding 30 days. So again, totally inadequate for a long COVID patient. But it does, however, say in an instance where there are medical complications, the commissioner has a right to review each case on merit. So your patient who sits in ICU for 40 days and then goes on through a long period of rehabilitation and takes possibly 6 months to recover, you as the treating doctor have to provide some sort of motivation and evidence why that is necessary so that this person under COVID, if it's an occupationally acquired COVID, can continue to receive benefits, whether that is wage replacement or have his medical treatment paid for under COVID as he would normally be entitled to. For confirmed cases, it's really the same. The fund accepts liability for these cases, but they only pay temporary total disablement up to 30 days. And again, where there are medical complications, the commissioner has a right to review each case on merit. So they deal with it on a case-by-case basis. But if the treating doctor submits sufficient evidence, I don't foresee any problem in getting the medical aid as well as the wage replacement for a longer period. When it comes to permanent disablement, again, this shall be assessed 3 months from the date of diagnosis. It's important to note that this directive was issued under the emergency regulations. And when the emergency regulations go, this directive will also go and will probably need to replace by something more permanent. But again, determining permanent disablement at 3 months, which is when most cases of long COVID will only be diagnosed, is a big problem for people with occupationally acquired COVID. In terms of reporting, it basically provides a whole list of which documentation should be submitted to the compensation commissioner or the employer, which list of documents should be submitted. I've just highlighted the one which is the final medical report in respect of an occupational disease, which is your WCL 26. And it says you need to submit that when the employee's condition has reached maximum medical improvement. It is highly unlikely, and I think the clinicians can attest to this, that many of your patients at 90 days at the 3-month period would have reached maximum medical improvement. Certainly not those with long COVID. So again, this is a bit of an issue. So moving on to social security benefits, and I've sort of just broadly divided it into occupational COVID and community acquired COVID. So the requirement for sick leave we've already ascertained is wholly inadequate. However, under occupational COVID, if you've got work-related COVID, you're a healthcare worker, it's very easy to prove work-relatedness. You'd be entitled to sick leave and treatment benefits for 3 months under COIDA. If you are a government employee and it goes beyond this, and for some reason you can't access that benefit under COIDA, you could probably access PILA, which is our policy on leave and incapacity, which allows for incapacity benefits, which is paid at practically 100% salary and could be paid for up to 2 years. When it comes to temporary incapacity benefits, many have to rely on the private insurer for temporary incapacity benefits. Again, government employees, in a sense, the PILA benefit would cover them. COIDA, it is unclear, and I have to point out here that COIDA for an occupational disease or significant injury would often allow for benefits up to a period of 2 years. But because it's brought out the specific directive for COVID, it has limited it to 3 months. And then obviously permanent incapacity. Again, under COIDA, one can make a case. If you know somebody has severe lung function impairment at 3 months, it's not going to improve. This person might be awarded a degree of permanent disablement, and it could be in the form of a lump sum or pension for life. Alternatively, you would have to access your private insurer, your pension or provident fund to access these kinds of benefits. Community acquired COVID. The sick leave is dependent on basic conditions of employment, which is roughly 30 days in a 3-year cycle, so 10 to 12 days per year, which is wholly inadequate, or employment service conditions or special leave. Government employees, certainly the Department of Health, were entitled to special leave, to isolate, to quarantine, so they didn't even have to access their sick leave. Again, for sort of longer term absence, pillar is a possibility for government employees, even if it's community acquired. There's also the unemployment fund. So at some point when all of this runs out, there has been the TERS benefit, which the government has brought on track, but we know there's been a sort of lapse in that. It went, I think, until last year, and then it was stopped. And now there's been a clamor from the unions, and I've just watched the news last night. It's going to be reinstated. So this is for your other workplaces. People don't have sick leave, but they need to go off on leave. So the unemployment fund can be accessed for that. In terms of temporary incapacity benefits, again, UIF, if it's for a period, you can say for the next 6 months. We do it for our TB patients sometimes, as well as private insurer temporary incapacity benefits, as well as disability grants, and again, your private insurer pension or provident fund when it comes to ill health retirement. If it looks all a bit too much, I think it is all a bit too much, and it's really hard for people to navigate this because our systems are not that easy. And certainly in the private insurance arena, you know, every insurer has their own sort of questions and their own set of forms that they want and their own information that they require before they make a determination on ill health retirement. So it's a big problem, or ill health benefits paying it out. The other issue I want to just bring to your attention is temporary incapacity benefits is a big problem. And if one doesn't have sort of top up from a private insurer that clearly speaks to it, it's a problem. And a lot of workers belong to an employer allocated pension fund or provident fund, and temporary incapacity benefits are often not included because it's a lot more expensive. So that has been, I think, a problem for many sort of people who's discovered, actually, you know, I'm not well enough to go to work. I probably need another 3 to 6 months, but actually I can't because then I need to be declared permanently unfit. And I don't think I'm permanently unfit. I don't want to. I want to have the option of working, but there's like no social security net other than UIF if one can access it. And UIF has not always been sort of nimble enough and quick enough to pay people out when they actually need the money. And I think it's worthwhile raising this because this adds to people's anxiety. You know, they already worried about their occupational functioning, they're not able to do their job, and now they're sort of out of pocket and having to worry about feeding themselves and keeping a roof over their heads. And that induces anxiety and all kinds of, I think, other issues which might impact negatively on their recovery and their health. So I think the challenges in treatment and rehabilitation for long COVID employees relate to the diagnosis. I think that there needs to be an explicit recognition of long COVID as a real post-viral disorder. It's not something in people's heads, or it's not people wanting to not come to work or just wanting a longer holiday. I think there has to be a recognition and provision of diagnostic facilities for such cases, or at least guidelines to aid diagnosis. And given, as Dr. Perumal has pointed out, the scope and the burden, it's too big. We need to tackle it even at primary care level. And so doctors would need training and maybe some guidelines. How do you spot these patients? How do you diagnose them? Because early diagnosis and referral to rehabilitation could really turn people around. And we know this from all sort of chronic cases that we see in the workplace. The earlier you intervene, the earlier you get people to treatment and rehabilitation, the greater the chance of recovery and a return to productivity. And then there's the small percentage of patients who are going to need specialist assessment and input for those with end organ damage and post-COVID sequelae, such as your myocarditis, your arrhythmias, or chronic lung disease. In terms of fitness to work and return to work, flexible working arrangements or graded return to work is needed. Pacing is what the rehabilitation specialists refer to, and that is often needed. A very strong rehabilitation focus is needed, and that's always been lacking, I think, in general in our sort of healthcare provision. Reintegration to your occupation for full productivity may take time. The law, however, does allow for accommodation and return to work strategies. And here I'm referring to the Labour Relations Act for incapacitated workers. And it says that employers must explore reasonably practicable measures to accommodate employees before considering termination and dismissal. It also allows for disability recognition and accommodation in the workplace. So where these workers do sort of end up still with a residual impairment, one could look at, could this be considered a disability, and therefore can be accommodated in terms of the Employment Equity Act. So greater flexibility from employers is needed to facilitate safe and productive return to work, and very important is the mental health support in the workplace and to decrease the stigma for these patients. So points to ponder that I think occupational cases of COVID are decreasing as community transmission is now entrenched. And we've also seen much improved implementation of prevention measures in the workplace. So the vast majority of these patients will not qualify for benefits under COVID, which in any case we've ascertained is not enough. Greater motivation is needed to access COVID benefits beyond 3 months for those of your patients with occupationally acquired COVID. And one must compare this to the general allowance for 2 years of temporary total disablement for significant occupational injury and disease. And one can argue that COVID would fall into that category. And so potentially this law is discriminatory as it stands. We are looking at a substantial caseload if long COVID affects approximately 30% of COVID infected, with a big impact on the workplace, and the diagnosis comes quite late at about 12 weeks only. So, the effects linger for a long time. I think that we need to rethink the fit or unfit paradigm, and this is both the employers and employees. And I think patients are often impatient with themselves and with the recovery because they expect to be back after a month or whatever, and they just can't get there. What we're rather looking at is a gradual pathway to fitness and full capacity. I think that this affects all categories of employees and all occupations. And we must remember that patients with long COVID often present with a constellation of symptoms. But just in that table below, you can see that if you have sort of neurocognitive impairments, which is very common, such as focus, concentration, and memory, this would impact very much on knowledge workers, safety critical occupations, people like teachers. If fatigue and impaired effort tolerance is your ongoing problem, then manual laborers, people who have to do physically demanding jobs, firemen, nurses are all going to struggle. If insomnia or sleep difficulty, which is also very common in long COVID, is a problem, shift workers will struggle because they need to sleep at set times and work at set times. So in conclusion, the science and occupational health safety law are currently not on the same page. The science has gone beyond, and I think the law needs to really catch up. What we need is a circular instruction or specific regulation for occupationally acquired COVID-19, and specifically long COVID. There must be emphasis on that. We need access to diagnostic expertise, care, and rehabilitation for long COVID sufferers. We certainly at the societal level need improved access to social security benefits, especially for temporary incapacity benefits. I would caution occupational health practitioners to follow a very principled return to work process with recourse for workers who may be unfairly terminated as a result of long COVID. And we need to assist those with long COVID who are not able to return to their former occupation or to be accommodated to access disability benefits. I thank you.
Thank you very much, Shahieda Adams, Associate Professor in the Division of Occupational Medicine at the School of Public Health and Family Medicine at UCT. Thank you very much. And a set of interesting recommendations at the end. I'm sure that our colleagues on the panel, as well as others who are in the audience in attendance, would be taking those recommendations up. And the question would be, how could the recommendations also be, I think, taken up with the specific authorities, structures, and committees where this can be addressed. Our next speaker is Professor Romy Parker. She's dealing with rehabilitation for long COVID. And by way of introduction, as Prof Parker is sharing the slides, Prof Romy Parker is a Professor and Director of the Pain Management Unit in the Department of Anesthesia and Perioperative Medicine at the University of Cape Town. She is an active researcher who has successfully supervised numerous postgraduate students. Prof Parker is the course convener for the Postgraduate Diploma in Interdisciplinary Pain Management, the first program of its kind in Africa. Prof Parker is an experienced physiotherapy clinician working in chronic pain management as part of the chronic pain management interdisciplinary team of Groote Schuur Hospital. Her research focuses on pain, with emphasis on developing and testing mechanism-based treatments relevant to a South African context. She serves as a counselor for the International Association for the Study of Pain, that is the IASP, from an African perspective. She is the current past president of Pain SA, the South African chapter of AISP, the past chair of Pain, Mind and Movement Special Interest Group of the AISP, and honorary life member of the Pain Management Physiotherapy Group of the South African Society of Physiotherapy. Prof Parker was awarded the UCT Distinguished Teachers Award for 2019, the university's highest honor for teaching. And with that introduction, Prof Parker, thank you for sharing your slides, and thank you for joining us today to share your experience and information and knowledge with us. If you could just check on your audio. Thank you.
All right, so I'm hoping you can hear me loud and clear. How's that?
Perfectly. Thanks.
Great.
Please proceed.
Thank you so much. And thank you for inviting me to join this session. And thank you to all the speakers who've gone before me, who've given us a huge amount of information about the burden of long COVID, about some of our theories, the current state of the science in terms of the underlying pathology of what might be contributing. And that really great last lecture, really getting us to grapple with some of the challenges of helping people with these sustained symptoms returning to work and how we can engage with that environment. So what I'm going to be speaking to you about is rehabilitation for long COVID. So I was going to spend some time defining the condition, but thank you, Dr. Perumal. He's covered that really nicely for us. So I'm going to take you through some methods that you can use clinically for assessing and reassessing symptoms in patients with long COVID, and then take you through the rehabilitation strategies that are being used by occupational therapists and physiotherapists in helping people recover from long COVID symptoms. And to be clear here, I think this has come up in the previous lectures, when we're referring to patients with long COVID for this type of rehabilitation, this is patients who do not have frank organ damage. So no frank evidence of organ damage, but they are struggling with relapsing and remitting symptoms of the acute illness. Fatigue, shortness of breath, and joint pain are really the primary symptoms that patients present with, but then that whole range of other symptoms that we have covered this morning. So assessing and reassessing. Where to start in assessing your patient? The first tool that I want to introduce you to is the recently developed post-COVID-19 functional status scale. So this is a very useful tool to grade the severity of your patient's symptoms, not just the severity of their symptoms, but how their symptoms are affecting their function. So you ask your patient how their symptoms have affected them in the last week. And the post-COVID functional scale asks the question, can you live alone without any assistance from another person? If the patient is not able to live independently, they're unable to manage activities of daily living, like preparing their meals, walking, dressing, bathing, that usual daily routine without assistance, if they say no, they're a grade 4. They are severely functionally limited. And the matching narrative that the patient would give you on this is that I suffer from severe limitations in my everyday life. I'm not able to take care of myself, and therefore I'm dependent on nursing care and or assistance from another person due to symptoms, pain, depression, or anxiety. As a clinician, you need to explore this carefully, because recently I found that when I ask patients this question, they say, yeah, I'm fine. I can do everything on my own. And the big question is, so are you doing your groceries yourself? Oh, no. I stopped doing my groceries. I got my friend, or I'm using an online grocery order thing. I could never make it round Checkers or Pick and Pay. That's severely functionally limiting. That is somebody who is not able to live without assistance. So they might not kind of recognize that they're asking for assistance because they're paying for somebody to bring their groceries to them, but that does mean that they have severe functional limitations. If they are able to live alone, they've said yes. Your next question is, are there duties or activities at home or at work which you are no longer able to perform yourself? So are there other things that you should be doing that you're unable to do? And if they say yes to that question, they're a grade 3 with moderate functional limitations. And certainly this is the majority of the patients I'm currently working with. I suffer from limitations in my everyday life as I'm not able to perform all my usual activities due to symptoms, pain, depression, or anxiety. I am, however, able to take care of myself without any assistance. So this is many people who have managed to get back to work, but they're just not able to get through a full working day, or they're very aware that they're functioning below what they regard as normal capacity at work and at home, in their relationships, in their roles and responsibilities as mothers and fathers and members of families and active members of communities. If they say no, your next question is, do you suffer from symptoms, pain, depression, or anxiety? And if they say yes, you're going to grade that. Of do you need to avoid or reduce duties or activities or spread these over time? If they say yes, I'm conscious that there are things I'm not doing, or that I'm being very careful about spreading my responsibilities over time, they're a grade 2, slight functional limitations. And the narrative is that I suffer from limitations in my everyday life as I occasionally need to avoid or reduce usual duties or activities, or I need to spread these over time due to my symptoms, pain, depression, or anxiety. I am, however, able to perform all activities without any assistance. So they can get through life, but they've got to plan it. They've got to be careful about how they manage it and how they do it. That's a grade 2. A grade 1 is somebody with negligible functional limitations. I have negligible limitations in my everyday life. I can perform all my usual duties or activities, but I'm still bothered by persistent symptoms, pain, depression, or anxiety. A 0, I'm not sure why you're using this tool on them. If they're scoring a grade 0, they have no functional limitations and they're not struggling with persistent symptoms. So this is a very useful tool as a baseline measure of how your patient is doing. Also a useful tool to measure change over time. And certainly in the patients we've been working with, we're slowly seeing them progress from a grade 3 to a grade 2, which is really encouraging for them and for us to see. Now, the other tool that I would suggest that you explore using is the Central Sensitization Inventory. This is a questionnaire that uses 25 questions and asks the patient how often they're experiencing them, and to report if it's never, rarely, sometimes, often, or always. And if you read through these, you will see there are a range of symptoms that include fatigue, muscle pain, anxiety and symptoms of anxiety and depression, symptoms that suggest central nervous system sensitization, such as photo and phonophobia and chemical sensitivity, and symptoms that cover the collection of sleep disturbances, so not sleeping well, restless leg syndrome, and waking feeling fatigued. You score this, never get 0, 1, 2, 3, and 4, and you total the score. A score of 30 to 39 is regarded as mild central sensitization, and a score of 40 or higher is strongly correlating with the pathophysiology of central sensitization. What is central sensitization? This umbrella term is referring to sensitization of the central nervous system, spinal cord and brain mechanisms, subcortical and cortical, unconscious mechanisms that contribute to a range of symptoms. And we see central sensitization in a whole collection of disorders ranging from fibromyalgia to irritable bowel syndrome, to chronic fatigue syndrome, and included in that are the post-viral fatigue syndromes. And so a long COVID symptom, a patient with long COVID symptoms, we would consider them in the collection of post-viral fatigue. So this is a very useful tool to measure the severity of central sensitization, but it's also sensitive to change over time. It's also an incredibly useful tool to assess a whole range of symptoms which patients often won't think to tell you about until you ask them about them specifically on a tool such as this. If one of the primary symptoms that your patient is presenting with in long COVID relates to pain, then a really well-validated tool is the brief pain inventory. And you can use this for both the assessment of acute and chronic pain. It has been translated and validated into most South African languages. And the brief pain inventory allows you to generate a pain severity score, which really just focuses on the sensation of pain. But perhaps more useful is the pain interference score, which tells you about how much their pain is interfering with their function. And these 7 questions on the right of this slide are the questions that you average to generate the pain interference with function score. So how much is pain interfering with your general activity, your mood, your ability to walk, your normal work, your relations with other people, your sleep, and enjoyment of life. The pain severity score, you average the scores for their worst pain, their least pain, their average pain, and their pain right now. And also very useful is the body chart. You ask the patient to color in on the body chart where they are experiencing pain. And there is good correlation between the presence of central sensitization, a nervous system that is overly sensitized to normal stimuli, and somebody drawing all over the body chart that they have pain in multiple areas. So the brief pain inventory, a really useful tool for baseline assessment and measuring change over time in patients with long COVID pain symptoms. So I noticed in the question and answer session, somebody referred to doing functional capacity evaluations and using that as a way of determining how badly the patient's affected and whether they are ready to return to work. And I want to express a word of caution with conducting such functional capacity evaluations using full physical, functional, and cognitive assessments in these patients. We have learned the hard way in other post-viral fatigue syndromes that patients are often able to complete the functional capacity evaluation, but they then become severely ill afterwards because of the neuroimmune mediated mechanisms that contribute to their symptoms. And patients report these as severe crashes. They end up in bed. They end up having to reduce noise and sound because they become so photo and phonophobic, and their cognitive and emotional ability becomes really severe. So it's not that they're not able to do the functional capacity evaluation, but that they don't recover from doing it. And there have been several case reports of functional capacity evaluations leading to severe long-term disability in patients who were moderately disabled prior to the functional capacity evaluation. So some caution in using that approach. So you've assessed your patient, you've established we've got no long-term organ damage, but my patient's struggling with ongoing symptoms, maybe functionally impaired in some way. Where are we going to go with rehabilitation? If on the post-COVID-19 functional scale, they're a grade 1 or 2, they have negligible and slight functional limitations, you want to consider referring them to a physiotherapist or to an occupational therapist, depending on their symptom collection. And the focus is on managing those symptoms and using activity scheduling to assist your patient with praying, with a personalized readjustment to activity embedded in it, to gradually increase their capacity to tolerate physical activity. If your patient is a grade 3 or 4, they have moderate or severe functional limitations. Again, you're going to focus on symptom management, but with a very, very carefully structured, personalized readjustment to activity on a daily basis. And I'll take you through what I mean by that. I just want to touch base on the symptom management. If shortness of breath or breathing disturbances is one of the primary symptoms that your patient is continuing to struggle with in long COVID, then your referral route is to a physiotherapist, either a physiotherapist with a particular interest in respiratory physiotherapy, but this kind of breathing rehabilitation is part of the undergraduate training for all physiotherapists. So all physiotherapists should be able to do this type of rehabilitation with patients. You're going to refer those patients with a focus on helping them to restore a normal breathing pattern. Diaphragmatic breathing and other breathing training is particularly important for these patients. You will notice when this patient is at rest or in conversation with you that they will lose a normal inspiration-expiration ratio, which should be a 1:2. They often are breathing apically. They're using all of their accessory muscles to assist with their breathing. And while that might have been appropriate during their acute infection, it becomes an unhealthy breathing pattern, an unhealthy habit of breathing, which contributes to ongoing shortness of breath and a feeling of being out of breath, lightheaded, and those unpleasant sensations that we all experience when we're out of breath. Most physiotherapists are doing telehealth consultations, so it's entirely possible to assess these patients and treat them in telehealth settings, which is very useful. Many of our patients continue to struggle with sleep. Sleep disturbance is a classic symptom in acute COVID, and it often continues post-COVID. First of all, sleep is a habit that we learn, and it often gets disrupted when we are acutely ill or go through stressful times in our lives. Poor sleep, disturbed sleep, sleep apnea, all reported. It may be linked to poor breathing patterns. So if they have poor breathing patterns, address those. It may be linked to post-traumatic stress disorder. So please screen for that and refer for treatment if it's present. But if it's simply about sleep, step 1 is putting into place the steps of sleep hygiene, resetting the habit of falling asleep routinely. If their symptoms persist after applying sleep hygiene diligently for 6 weeks, then it may be a referral. It may be appropriate to refer your patient to a sleep lab. There's also a role for mindfulness or relaxation strategies. I think we're all aware that prolonged mental health symptoms are rising in the population as a whole. I'm not sure how you are all feeling with this third wave, but certainly I'm acutely aware of changes in my own mental health. And if you have suffered with an acute COVID-19 infection, you may suffer with prolonged mental health symptoms from that in combination with living in a pandemic. So patients are reporting anxiety and panic attacks, memory issues, cognitive impairment, depression, difficulty with word finding. And in all of these symptoms, mindfulness-based strategies are level 1 evidence treatment approach. That's your starting point. So mild to moderate depression, anxiety, and other symptoms should be referred to physiotherapy and occupational therapists who will teach patients the skills of different mindfulness and relaxation strategies and integrate the application of those strategies on a daily schedule. It's not that you just do it once or twice, it needs to be part of a daily routine. Patients who are struggling with moderate to severe mental health symptoms do need referral to psychology or psychiatry. Now, I'm acutely aware of how quickly time is going. and I want to talk you through activity scheduling, which is probably the fundamental pillar that needs to be put into place for rehabilitation of patients with long COVID. And I would suggest that probably every patient recovering from COVID needs to think about activity scheduling. We all make the mistake of being acutely ill and lying on our beds or the couch for a week or 2 weeks, and then we're told we're fit to return to work, and we go from spending 90% of our days horizontal to trying to go back to work. We must encourage patients to activity schedule, to start to restore their tolerance for activities and restore their fitness before they just go back to work. So in activity scheduling, we help patients to break tasks into achievable components. We often use a daily timetable. We'll plot the day. What time do you get up? Then what do you do? Then at 7:30, what are you going to do? Then you're going to leave the house. Before you go back to work, that shouldn't be the first time you leave the house. The day before you go back to work, you should practice leaving the house at the time that you go back to work and sit in the traffic and remind yourself how exhausting and stressful that can be before you've even got to the office. Helping people to rehearse the return to work process is critically important in helping them achieve success in returning to work. When we start with activity scheduling, particularly in patients who are fatigued, we use short bouts of activity with longer bouts of rest, and typically a 1-to-2 ratio. So if you manage to do activity for 15 minutes, pottering around the kitchen, chopping vegetables and sweeping the floor, you're then going to spend 30 minutes resting. And the day progresses in that way using that ratio. Once you've developed a ratio like that, a schedule like that, and the patient has used it for probably at least 2 weeks, we might then progress them over time to a 1-to-1 ratio, and finally a 2-to-1 ratio, 2 bouts of activity to 1 bout of rest, which is essentially what most of us do over a 24-hour period. You know, we're active for 16 hours and we like to sleep for 8. Well, I do. I like to sleep for 10. But a 2-to-1 ratio is relatively normal. And we're trying to help people restore that normal activity rest ratio. It's really important to emphasize to patients that relaxation time, breathing, mindfulness, it is all active rehabilitation. And my patients who look confused at me about that, I just remind them that, you know, in athletes who are training for the Olympics, overtraining syndrome is a problem if they don't schedule rest. Rest is a critical part of a healthy system. And rest may need to be complete rest. They may need to have sleep during the day if they're particularly exhausted. Sleep during the day is contraindicated, however, if they are not sleeping at night. We also engage with patients on differences in the quality of the rest that they gain when they're resting and reading, or resting and listening to music, or I consulted with a teenager this week. Resting and being on social media is not rest. Social media is cognitively and emotionally exhausting. So engaging with what rest actually is important. And for patients who are suffering with POTS, then the most beneficial rest for them is in supine, or at least a minimum rest with their legs elevated. In these activity schedules, we must holistically consider that it's not just about physical activity, but emotional activity and cognitive activities all use our energy and contribute to fatigue. And so throughout our activity schedule, we ask patients to consider how much physical activity are you doing? Now, what's the emotional activity you're going to do? Yes, your friend can come and visit you and you can sit outside and have tea. That's half an hour's emotional activity. But if you're going to go and meet them at a coffee shop, that's physical and emotional activity. Do you have the energy for that? And how are you going to schedule the rest around a double activity such as that? And if you think about a normal day's work, for most of us, it's physical, emotional, and cognitive. We need to build up people's tolerance to be able to get back to work in all 3 dimensions. How do we progress? Initially, we keep increasing rest until your patient is stable. Many of our patients feel like their symptoms have control of them. And so we first focus on helping them get a grip, helping them feel like they have some sense of understanding of what's going on in their bodies. So we keep increasing rest until they feel like they're not spiraling out of control. And then we gradually start to increase their activities in 10% increments. And physios and OTs will always ensure that we are doing this around patient-centered, meaningful goals from day one, making sure that our patients aren't just getting back to the job that they do because they have to, but they're getting back to doing the things in their lives that are important, like playing with their children or spending time with their loved ones. It's really important that we address the whole person. So, to return patients to physical activity, to return them to work, we must schedule activity in their rehabilitation. We need to prepare them for returning to physical activity before we return them to physical activity. When patients are wanting to engage in physical activity, whether it's work-related physical activity or sport, then this guideline from Salman and colleagues that was published earlier this year in the BMJ is incredibly useful. I'm not going to take you through it, but the key point that I want to point out to you is that you need to remain at each phase for 7 days before you progress to the next level of physical activity. And I think the biggest mistake that everyone makes is too much too soon. Everyone just tries to rush back to getting back to doing my 5K run at the speed that I've always done it. Whereas if we look at this recovery profile, it's going to take 4 to 5 weeks if everything goes smoothly before you get to that point. So physical activity must be individually negotiated. Patients are very fearful of relapsing, and so be conservative in your prescription of physical activity. Also need to consider physical activity exertion in all of our daily activities. Patients often forget the physical exertion of walking to catch the taxi or being in a crowded bus, not just the physical activity of their jobs or their sports. And in prescribing physical activity, physiotherapists will always consider the frequency, intensity, type, and dosage, and how they're going to progress the patient over time. In terms of dosage, what's useful to look at is this graph. So we all like to think that we're going to increase our levels of activity according to the green line. But in reality, very few people are able to progress in that kind of trajectory. What is more likely is the orange line, that you progress and you stabilize and you progress and you stabilize and you progress, and you might go back a little bit and then you progress a little bit more slowly. So you might go from the yellow down to this orange line, okay? It is still progression. What patients often try and do is 10 minutes today, 15 tomorrow, 20 the day after, and follow a exponential trajectory almost on the exercise prescription. Exercise prescription requires careful dosage and progression over time. The patient, the therapist, and the support structures, everybody needs to be flexible on this. And a graduated return to work might need to be negotiated. I might need to start off going to work in the mornings on a Monday, Wednesday, and Friday, and then do mornings all week, and then do Monday, Wednesday, Friday full days, but have a half day on a Tuesday and Thursday before I'm able to get back to doing my job full time, full on. It takes time to build my tolerance and endurance to get back to my work. So if you're looking for rehab professionals, occupational therapists and physiotherapists are the people that you should be working with to help your patients return to full function and engagement in their meaningful life roles. Rehab professionals who work with people with chronic pain will have these primary tools available to them. They are using them with people with chronic pain all the time. And physiotherapists who are working in the field of COPD rehab will also be familiar with these rehabilitation strategies and using them all the time. You can access a clinician list of people who've done particular training in chronic pain management at this website of the Trained Pain Academy. And these are some resources and references that might be useful for you. So thank you for listening to me. I'm sorry to have taken the time right up to 12:30. I hope that some of this will have been useful for you.
Thank you very much. That's Professor Romy Parker. Thank you very much for your valuable contribution. And I'm sure that our attendees would find this very useful because you've contributed an important element to the mix of what we've offered today in the webinar. So that's Prof Romy Parker, the Professor and Director of the Pain Management Unit at the Department of Anesthesia and Perioperative Medicine at the University of Cape Town and associated with Groote Schuur Hospital as well. So we have about 5 or so minutes for some looking at questions. I know that we've been successfully dealing with all the questions, question answer box. And maybe what we could do, just a quick reflection, starting with Dr. Dryden. Having looked at the questions that we've had in the Q&A box, having heard the other presenters, what are those final remarks and priority points you'd like to share in about, say, a minute or so with our attendees, Dr. Dryden?
Thank you so much, Ashraf. So just to reiterate, obviously long COVID is something, or post-COVID-19 is something that's continuously evolving. There still isn't a universally internationally recognized definition for it. Even with us writing papers, there's arguments between all of our authors with regards to what we should be referring to it as. In terms of the definition and what it is also clearly under discussion. But just to reiterate, the most important thing for patients at the moment is that they need to be validated in what they're feeling, to be reassured in the complaints that they have, and that they're not alone. There are quite a lot of patients that have it, and particularly within my own personal group, I have a few friends that have got long COVID. At some points, I've thought that I've had it too. Unfortunately, I've been vaccinated, so I'm not sure. But yeah, it's something that we do need to take into cognizance, particularly from an occupational side, impacting not only people at a personal level, but at a national level. So this is something very important. So thank you to the other speakers, and thank you for opening the invitation to us to present. And I hope to be back with you guys again soon.
Yes, certainly. I think that this topic is something that we will probably follow up one or more occasions as we go forward. Clearly, the developments around variants, etc., might mean that we need more updates on this as well. Thank you, Dr. Dryden. And thank you to your team, including Dr. Waasila Jassat, who has also contributed to previous webinar. Dr. Perumal, unfortunately, has got urgent clinical responsibilities in his clinic at Groote Schuur Hospital and had to leave slightly early, but I'll move quickly to Prof. Adams. Do you have any specific observations given the questions we've had in the Q&A box, the trends there, as well as the contributions from our colleagues? Over to you, Prof.
Thank you, Ashraf. So I would agitate for the occupational health practitioners, because I'm also a clinician and occupational medicine doctor amongst us, to think about long COVID when they're doing a return to work fitness on patients with COVID who's come back to the workplace, and to have a high index of suspicion in those with ongoing difficulties in doing their job. I think that, it becomes quite mechanistic. Let's fill out the forms, let's get people back. They've had the 10 days of isolation, and we don't sort of spend the time and give our patients the space always to tell us exactly how they're feeling and whether they really are fine to go back to work. And down the line, it catches up, because the same patient then comes back after 2 or 3 weeks, not really able to cope. That's the one thing. And the other thing is there clearly is a need for long COVID to be recognized, in spite of the limited data. I do think we have enough data to know that this is real and this is having a major impact on people in terms of impairment, and not just in their working life, but also in their daily lives, for people to just return to activities of daily living and to be independent. So I think to recognize this as a real entity and to try to manage it as best as we can, both within and outside of the workplace, and to support our patients. Yeah.
Prof, just to slip in something, I know Anthony Hawkridge has typed his question in the wrong box, in the chat box, or not the question answer box. Is there a detectable signal, or I guess trend is probably what he's asking, in our absenteeism rates yet? Any insights you might want to share there?
I don't know the data, so not offhand, but looking at the data, I mean, internationally, definitely there's an impact on absenteeism and people's ability to return to work productively. Anecdotally, yes, I get, like I say, we get queries almost on a weekly basis of patients like this who, are struggling to come back. I sit on the incapacity management committee for GSH, and we're not really seeing the tsunami yet, but I think it's going to come. So I think it definitely is going to have an impact on absenteeism.
Thank you very much. That's Professor Shahieda Adams from the Division of Occupational Medicine, School of Public Health and Family Medicine at UCT. And then for final remarks, Prof Parker, thanks again for your great contribution there. You probably had seen the question and answers or the questions that have been asked there in the Q&A box before your presentation. And any final remarks from your side?
I think a couple of important things when patients are suffering from long COVID, reassure them that 30% of people who've experienced COVID have a prolonged recovery. So I think that's really reassuring for patients to know that they're not the only one. And if you can have support groups at workplaces is really helpful for them. But then sit down and plot a recovery profile for them. Sit down and get a spreadsheet and work out how much are they able to do now. Are they at 60%? Do an activity schedule with them, or get an occupational therapist or a physiotherapist to do an activity schedule and show them that by September or October, they're going to be back to 100%. It's really useful for people to have a sense of the way forward of where they're going. It really reduces their anxiety and the feeling of just being lost with these symptoms.
Thank you, Prof. Parker. An interesting comment made by one of our attendees with regard to long COVID, if I can quickly find it. In response to Prof. Adams, I sense that the increase in occupational accidents may be because of long COVID. I've added a couple of words there to improve the sentence. That's from Okud Swanepoel. From any of our panelists, are there indications that long COVID of those employees who have returned to work might impact on general safety scenarios at work? And the first one, yeah, I see Prof. Parker and Prof. Adams.
Ashraf, so I think, Ashraf, that I haven't seen data to that effect as yet. But I mean, if you think, especially around the neurocognitive effects, that it impacts on concentration, focus, as well as I think the psychological impact that a lot of workers experience a loss of confidence, because they often were high functioning, quite competent, and now they just can't do things that seemingly is like the bread and butter of their job they should be able to do with their eyes closed. So potentially, I think that risk is there, particularly with the neurocognitive impacts. If your concentration and your executive function and your focus is impacted, then you are able to make more mistakes in the workplace, but I haven't seen data to that effect.
Thank you very much for that. I'm not sure if there were any other input or comments. I did see your microphone open, Prof. Parker. That might have been an old microphone. If not, it is at this point that I probably need to just thank all of you greatly for your contributions. And I'll quote Paulina Letsualo, who says the following in the chat box. Thanks a lot for thanks a lot with the information received, for the information received. As an occupational, I guess that's occupational health nursing practitioner, this info will benefit the employee and employers to manage the long COVID in the workplace. Thanks for the questions raised. They were an eye-opener. So on behalf of all of the attendees, I've quoted Paulina to just say thank you very much to Dr. Murray Dryden from the NICD, Dr. Waasila Jassat, his partner in preparing, doing the research and stuff there at the NICD, Dr. Rubeshan Perumal from the Long COVID Clinic at Groote Schuur Hospital, Professor Shahieda Adams from the Division of Occupational Medicine, at the School of Public Health and Family Medicine at UCT, as well as Prof Romy Parker from the Department of Anesthesia and Perioperative Medicine at the University of Cape Town. And both of them also have association with clinical activity at Groote Schuur Hospital. Thank you very much, gentlemen and ladies, for your contribution. It is very much appreciated. And to all of our attendees, thanks for joining us today. We will be coming up with the next webinar, and one of it is particularly for those companies who are registered on the Occupational Health Surveillance System, which is run by and managed by the NIH. That will be next week, Wednesday. But on Thursday, we have a webinar dealing with COVID-19 and skin conditions in the workplace. That's Thursday, the 15th of July. This Friday, tomorrow we're having a webinar that deals with ergonomics in the construction sector in partnership with SAFSEC. So thank you everybody for joining today. That's it for this webinar. Goodbye. See you on the next webinar. I'll just be checking if there's any questions left in the question and answer box, and encourage our presenters and speakers just to have a quick look there before we depart. Thank you very much. Goodbye.